Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome again my dear students in my surgery lecture number 59, that is the retention of the urine and urinary diversion. In this lecture we will continue to learn the retention of urine, causes and its management, urinary diversions operations, method of the urinary diversions, Uretero-Sigmoidostomy, ileal conduit, colon conduit and Lossley's operation. All these points are covered in this lecture. So let's start with me. First, the retention of the urine. Retention of urine means the accumulation of urine in the urinary bladder. The patient is unable to pass urine or passes small quantity of urine. It must be remembered that there is a difference between the anuria, in which the kidney fails to excrete the urine, and there is no urine in the urinary bladder, that is the anuria, and the retention of urine, in which the kidney excretes the urine normally and the urinary bladder contains urine but the patient is unable to pass urine. This is the difference between the anuria and the retention of the urine. There is one similar in anuria and retention of urine, that is the patient fails to pass urine. In the both these conditions, retention of the urine can be of three types. First is the acute retention, second is the chronic retention, and third is the acute on chronic retention. First, acute retention is sudden inability to pass urine and it is the painful condition. Second is the chronic retention, is gradually accumulation of urine in the bladder due to the inability of the patient to empty the bladder completely. The result is an enlarged painless bladder which may reach up to the umbilicus without even knowledge to the patient. Third is the acute on chronic retention, is a condition in which acute retention superimposes on chronic retention. That means a patient who is already suffering from the chronic retention and the bladder is already half full, suddenly the patient becomes unable to pass the urine at all and the bladder becomes completely full with a terrific pain. Dear students, here is the image. You can see there is a normal flow of the urine and there is obstructing due to the benign hypertrophy of the prostate, the restricted flow. That's why there is a retention of urine. There are the many causes of the retention of the urine as we see in this lecture. This is the another image showing the retention of the urine. The below umbilical area is distended, bladder is full, is clearly seen in this image. Now the causes of the retention of the urine. First is the mechanical, urinary bladder, stones, tumors, blood clots and contracture of the bladder neck. Second is the prostate. In the mechanical reasons of the retention of urine is the prostatic abscess, benign and malignant prostatic enlargement. Third is the urethra. In the mechanical causes of the retention of urine are urethral stricture, rupture, congenital valves, foreign body, acute urethritis, stone growth, pinhole meatus, meatal ulcer with scarring. And the fourth prefusal mechanical reasons of the retention of urine is the phimosis. From the outside, the pregnancy, retroverted gravidated fibroid, ovarian cyst, carcinoma of the cervix, uteri and the rectum and any pelvic growth causes for the retention of the urine. Now the second cause, main cause is the neurogenic cause for the retention of the urine are the spinal cord disease, that is the disseminated sclerosis, Tape's dorsalis, transverse myelitis, etc. Second is the injuries and diseases of the spine, that is the fracture dislocation, Pott's disease, etc. Miscellaneous, that is the post-operative retention, hysteria, tetanus, drugs such as the anticholinergic, smooth muscle relaxant and tranquilizer, etc. Now the clinical features. Typical symptoms is that the patient has not passed urine for several hours. In acute retention, the patient is in the extreme pain and he wants to be relieved immediately. Presence of the distended bladder. In males, the common causes are BHP, means benign hypertrophy of the prostate, and malignant prostate and the urethral stricture. In females, these conditions seen in pregnancy, retroverted gravidatorus in fibroid, in case of the rectal or pelvic growth in multiple sclerosis and hysteria. Now the management. After the careful examination to detect the cause of the retention of urine, a dose of the Omnipon is administered to relieve the anxiety and the patient should take a hot bath to diminish the internal congestion. Hot and cold application may be given to the suprapubic region. These sometimes help the patient to pass the urine by diminishing the congestion of the bladder neck. If this fails, a catheter should be passed, preferably in the operation theatre using full aseptic care. If after considerable attempts with various catheters, catheterization into the bladder has not been possible, one of the following four methods may be adopted. First is the suprapubic puncture, second is the suprapubic cystostomy, third is the immediate prostatectomy, fourth is the urethral instrumentation. Retention with flows. In this condition, the patient fails to control so that small amounts of the urine come out involuntarily from time to time from a completely filled bladder. It easily flows. A neglected chronic retention cases through it may occur rarely in acute retention also. Retention with overflow has also been referred under the incontinence and the prostatic enlargement. The treatment is decompression of the bladder, which must be carried out slowly. Now, the second point of this lecture is the urinary diversion. Urinary diversion means the diversion of the urinary pathway from its natural path. Urinary diversion may be the temporary procedure to relieve distal obstruction, that is the tube nephrostomy. It may be performed as a permanent procedure, and this reconstructive surgery is gradually requiring a commonplace. The indication for the permanent urinary diversions are when the bladder has to be removed, when the sphincters of the bladder and the detrusor muscles have been damaged or have lost their normal neurological controls, when there is an irremovable obstruction in the bladder and the distal to that, in case of the ectopic fascicle, and when there is an incurable vesicovaginal fistula. In all these conditions, the urinary diversion is to be made. Dear students, here is a image showing the stoma of the urinary diversion, catheter opening. The urinary diversion stoma is clearly seen in this image. This is the another image showing the urinary stoma. Here is a picture of the ileal conduit. The part of the ileal conduit on the skin is seen. Here is the same picture. Stoma, urostomy opening is seen in this picture. These are the three pictures showing, first showing the ileal conduit, incontinent diversion of the skin. Second showing the continent cutaneous reservoir, continent diversion to skin, and third is the orthotopic neobladder, that is the continent diversion of the urethra. This is the picture of the ileal conduit again seen. Here is the nephrostomy tube is put in the kidney calyces, another diversion of the urinary diversion. Now the methods of the urinary diversions are, there are various methods of urinary diversion which includes both temporary and permanent procedures. This type of the operation to be used in the particular cases should be judged according to its merit. The methods are pylostomy and nephrostomy or ureterostomy, which indwelling catheters, that is the temporary procedures. Suprapubic cystostomy, this is also the temporary procedure. Bladder diversion, rectal bladder, cutaneous ureterostomy, Uretero-Sigmoidostomy, ureteric transplantation into the isolated ileal or colonic conduit. Here is the image, you can see the stoma, the segment of the intestine, ileal conduit. Now the commonly used methods are the Uretero-Sigmoidostomy. The advantages of the diverting urine into the colon is that no collection apparatus is necessary. However, anal sphincter must be competent. Before performing this operation, the patient must prove that he can control at least 200 ml of fluid in the rectum. This operation is intact and first widely employed and successfully form of the intestinal urinary diversion. With the advent of ileal conduit, many urological surgeons have abandoned this operation due to its complication of the hyperchloremic acidosis, because the colon is reabsorb the sodium through the colon, and there is a hyperchloremic acidosis. Now the complications of this operation is the reflux of the urine. Pressure within the colon may cause reflux of the urine opposed to the kidney. That is why the Leadbetter made the anastomosis through the muscular and the submucosal tunnel to prevent this. Sigmoid myotomy has been performed to decrease the intracolonic pressure to overcome this problem. Second is the biochemical changes. Sigmoid colon absorbs chloride and urea, and this causes hyperchloremic acidosis. In these cases, there is following this operation. There is also potassium depletion. When severe, the patients the complaint of loss of appetite, weakness, thirst, diarrhea. Gradually the respiration becomes the rapid and deep. These cases may produce osteomalacia from calcium excision, bone pain, and even pathological fractures may occur. The patient should avoid added salt in the diet. On the contrary, he should take a mixture of potassium citrate and sodium bicarbonate thrice daily. Here is a Uretero-Sigmoidostomy, and the picture is clearly showing by the Leadbetter anastomosis through the muscular and the submuscular tunnel to prevent the colonic reflux of the urine opposed to the kidney. This is the typical picture showing that, and this is the Uretero-Sigmoidostomy is clearly seen in this picture. Next is the renal infection. Next complication is the renal infection. Organism from the sigmoid colon may find easy access through the ureters into the kidney and cause the infection like pyelonephritis, which becomes difficult to control. And fourth is the stricture formation. There is a possibility of the stricture formation at the anastomosizing site. Now, ileal conduit. This is the most frequently employed form of the permanent urinary diversion. For this ileal conduit, you can refer a good video on YouTube is available for the ileal conduit and the colon conduit operation. You can refer it, watch it to clear your concept. Dear students, now the results and the complications. Complications like of the ileal conduit are infection, urinary leakage of the ureteroileal anastomosis is the complication which can be avoided by the meticulous anastomosis. It depends on the skill of the surgeons. Viability of the terminal portion, stenosis at the uretero-ileal junction and the stricture of the ileal loop, and reabsorptive problems is there like the hyperchloremia acidosis. Dear students, here is a good picture of the urine stoma. Ileal stoma is seen. There is a urine bag on this image you can see. Here is a picture of the ileal conduit, selection of the loop of the ileum. The blood supply is preserved there. You can watch it clearly. Another picture of the urinary stoma. This is the part of the ileal conduit, completed ileal conduit clearly seen. Now the colon conduit, ileocecal segments, use of the cecum and terminal ileum as the bladder substitute has been used with some success. Now the Lossley operation, the rectosigmoid junction is divided completely and its lower end is closed. The ureters are implanted into the excluded lower segment so that the rectum now functions as a bladder. The proximal cut end of the sigmoid colon is now mobilized sufficiently to draw through the perineum anterior to the anus within the external sphincter, so that both of the original canal and the new canal are surrounded by the external sphincter. It is called the rectal bladder. Dear students, you can see clearly in this image, the image A showing the Leadbetter type, that is the ureter end is sutured in the wall of the ileum, and next is the Nesbit type, that is the ureters is perpendicularly sutured with the ileum, and third is transversely suturing, that is the Cordonnier type, is clearly seen in this picture. Here is a colon conduit, picture of the colon conduit. Both ureters are sutured in the part of the colon, that is the rectal bladder you can see. Dear students, you can refer the textbook to clear these points, and also there is a good videos on the YouTube. You can also refer there. Here is the end of our surgery lecture number 59, that is the retention of urine and urinary diversion. Thank you students.